Percutaneous transcatheter closure of congenital interatrial communication, i.e., Fontan fenestration, atrial septal defect, with implant. A congenital atrial septal defect is closed percutaneously by catheter. This procedure may be performed on infants or adults, usually under moderate sedation. After heparinization in induced, a combined right and left heart catheterization is first undertaken through the existing septal opening. Contrast material is injected for atrial and ventricular angiograms to map the anatomy. Using a specialized catheter, the atrial defect is crossed from the right atrium into the left. The catheter is threaded into the upper left pulmonary vein. A guide wire is inserted, the catheter is removed, and a balloon is threaded over the guide wire into position across the defect and inflated with low pressure. The stretched diameter of the defect is measured. Testing is carried out to ensure that the repair will remain hemodynamically stable by occluding the defect temporarily with the balloon while taking right side pressures and saturation measurements. A dilator and sheath holding the device are advanced over the guide wire and positioned in the left atrium. Positioning is checked using echocardiography or fluoroscopy before releasing the device. The implant is deployed across the atrial opening and positioning is checked again. Any leaks, abnormal placement, or an improperly sized device may require removal of the implant and placement of a second device. The catheters and guide wires are removed. Percutaneous transcatheter closure of a congenital ventricular septal defect with implant. A congenital ventricular septal defect is closed percutaneously by catheter. The patient is given local anesthesia and the femoral artery and vein are cannulated. A guide wire and catheter are inserted and advanced through the ventricular septum, into the right ventricle, and across the tricuspid valve into the right atrium. A separate venous sheath is placed in the jugular vein to allow passage of a snare catheter. The snare is advanced into the atrium and grasps the free wire or catheter that was threaded through the ventricular septal defect. This provides a through and through from the femoral vein to the ventricular septal defect and out the jugular. The jugular end is used to pass a dilator and sheath over the defect for the positioning of the occlusive device into the left ventricle. The sheath must be in the exact position with its tip in the left ventricle for delivery of the occlusive device. If necessary, traction is used at the opposite end to secure the sheath as the dilator is removed. If the sheath is displaced during removal of the dilator is reinserted for correct positioning. Once the sheath is in place and the dilator removed, the delivery catheter loaded with an occlusive device is advanced to the center of the right atrium. The device is advanced out of the delivery catheter and into the tip of the sheath. It is gently advanced so that the distal legs are in the left ventricle and the center of the device is in the defect. A slight withdrawing of the sheath causes the distal legs to open within the left ventricle. Further withdrawal of the sheath allows the proximal legs to open in the right ventricle. The occlusion is confirmed with angiography and the delivery system and catheters are removed. Percutaneous transcatheter closure of patent ductus arteriosus. A patent ductus arteriosus, PDA, is closed using a transcatheter technique. A small incision is made in an extremity artery, usually the femoral artery. The physician threads a catheter through the arteries and heart to the PDA. A coil or other occlusion device is deployed into the PDA via the catheter. An angiography may be performed to check for patency of the closure device. The catheter is removed and the incision is closed. Percutaneous transcatheter septal reduction therapy, e.g., alcohol septal ablation, including temporary pacemaker insertion when performed. Septal reduction therapy, also known as alcohol septal ablation, ASA, is performed to decrease the size of the cardiac septal muscle in patients with hypertrophic cardiomyopathy. A small incision is made in an extremity artery, usually the femoral artery. A catheter is threaded through the arteries to the heart and a coronary angiography is performed to locate the first septal perforator branch of the left anterior descending, LAD, artery. A balloon is inflated within the perforator and contrast is injected to ensure no flow back into the LAD. A slow injection of absolute alcohol is performed until a partial initial response is rendered. The balloon is deflated and an additional coronary angiogram is performed to ensure patency of the LAD. The catheters are removed and the incision is closed. Percutaneous transcatheter closure of paravalvular leak, initial occlusion device, mitral valve. Initial occlusion device, aortic valve. Each additional occlusion device. Percutaneous transcatheter closure of a paravalvular leak, PVL, in the mitral or aortic valve can be achieved by antegrade or retrograde approach. A transesophageal echocardiogram, T, for a mitral valve leak or a transthoracic echocardiogram, TTE, for an aortic leak was performed within the previous 6 months, earlier if the patient was symptomatic. A retrograde transfemoral approach is performed utilizing a catheter and guide wire. Upon crossing the leak, the wire is removed and a stiff wire is inserted along with the device delivery system consisting of a guide catheter or sheath. The wire is removed allowing for advancement and deployment of an occlusion device. In cases where support becomes an issue, a transseptal access and snare may be employed to establish a rail. This entails the snaring of the initial wire within the left atrium or the formation of an apical ventricular rail by left ventricular puncture with the wire crossing the apex. In mitral PVL, if this approach does not achieve the desired results, an antegrade transseptal approach may be used. Upon completion of the procedure for 93,590, T should indicate fluent leaflets, clear pulmonary veins, and if anterior leak, clear mitral valve. In 93,591, the physician must evaluate that the coronary ostia is not covered and leaflets are fluent. For both procedures, the device deployed is dependent upon the defect's size. Many closure devices are currently used in these procedures, such as embolization coils, double umbrella devices, occluders, and plugs approved for other specific defects and may be suitable in most cases. However, for PVLs they are limited by size, shape, specific characteristics, and features of delivery system. Report 93,592 for each additional occlusion device. Bundle of his recording. The physician places a venous sheath, usually in a femoral vein, using standard techniques. The physician advances an electrical catheter through the venous sheath and into the right heart under fluoroscopic guidance. The physician attaches the catheter to an electrical recording device to allow depiction of the intracardiac electrograms obtained from electrodes on the catheter tip. The physician moves the catheter tip to the bundle of his, on the anteroseptal tricuspid annulus, and obtains recordings. Alternatively, the physician may obtain similar recordings by placing a catheter into the left ventricular outflow tract via the aorta. Intraatrial recording. The physician places a venous sheath, usually in a femoral vein, using standard techniques. The physician advances an electrical catheter through the venous sheath and into the right heart under fluoroscopic guidance. The physician attaches the catheter to an electrical recording device to allow depiction of the intracardiac electrograms obtained from electrodes on the catheter tip. The physician moves the catheter tip to the right atrium and obtains recordings. The physician may obtain left atrial recordings by crossing the interatrial septum. Alternatively, the physician may obtain left atrial recordings by placing an arterial catheter into the aorta and crossing both the aortic and mitral valves in a retrograde fashion. Right ventricular recording. The physician places a venous sheath, usually in a femoral vein, using standard techniques. The physician advances an electrical catheter through the venous sheath and into the right heart under fluoroscopic guidance. The physician attaches the catheter to an electrical recording device to allow depiction of the intracardiac electrograms obtained from electrodes on the catheter tip. The physician moves the catheter tip to the right ventricle and obtains recordings. Intraventricular and/or intraatrial mapping of tachycardia site, S, with catheter manipulation to record from multiple sites to identify origin of tachycardia. The physician places an appropriate arterial or venous sheath, usually femoral, to allow access to the chamber to be mapped. The physician advances an electrical catheter through the sheath and into the appropriate chamber under fluoroscopic guidance. The physician attaches the catheter to an electrical recording device to allow depiction of the intracardiac electrograms obtained from electrodes on the catheter tip. The physician moves the catheter tip throughout the chamber to be mapped and obtains recordings. The physician compares activation times from different sites in order to identify the origin of the tachycardia. Interatrial pacing. The physician places a venous sheath, usually in a femoral vein, using standard techniques. The physician advances an electrical catheter through the venous sheath and into the right heart under fluoroscopic guidance. The physician attaches the catheter to an electrical pacing device to allow transmission of pacing impulses through the catheter to the right atrium. The physician may pace the left atrium by placing the catheter in the coronary sinus or by crossing the interatrial septum. Alternatively, the physician may pace the left atrium by placing an arterial catheter into the aorta and crossing both the aortic and mitral valves in a retrograde fashion. Intraventricular pacing. The physician places a venous sheath using standard techniques. The physician advances an electrical catheter through the venous sheath and into the right ventricle under fluoroscopic guidance. The physician attaches the catheter to an electrical pacing device to allow transmission of pacing impulses through the catheter to the right ventricle. Alternatively, the physician may pace the left ventricle by placing the catheter in the right atrium, crossing the intraatrial septum and mitral valve. Finally, the physician may pace the left ventricle by advancing a catheter through an arterial sheath, via the aorta, across the aortic valve into the left ventricle.